that you come away with a much better. My hope is that you come away with a much better understanding of what ADHD is in order to help patients kind of better understand their diagnosis. All right. So a lot of text here, but a little bit of history. Um, there's some thought, I think, in like social media and other places that ADHD is like a new phenomenon, a new diagnosis. But these symptoms and symptom clusters have been described since like the 1770s, maybe a little bit earlier, and have been researched kind of and elaborated on over time since then. So in the early 1900s, there was this idea of kids with these traits of hyperactivity, impulsivity, being, quote, brain injured or spoiled. Those were the terminology that were used back then, like a lot of terminology from the early 1900s, maybe not as appropriate today. Um, in the 1930s was the first time that stimulants were known to be helpful for these children. At that point, they called them disruptive youth. And then in the 50s to about the 70s or 80s, this idea or term, minimal brain dysfunction, was being used quite a bit. Um, the 70s was the first time where we started actually using stimulants to treat ADHD type symptoms with good success. Um, uh, and around that time was kind of the first time that we recognized as a community that this was an organic disorder, number one, primarily an organic disorder, number one, that also affected adults. So prior to this, this was considered a disorder of childhood. The 1980s was the first time that we actually codified the term attention deficit disorder and put together some clinical criteria around this. That was revised to attention deficit hyperactivity disorder a little bit later on. And then that was also the first time that instead of just focusing on psychopharmacology and stimulant use, there were some trials of CBT and other psychotherapeutic interventions to help treat ADHD. Um, the 1990s was when really, and this wasn't that long ago, was the first time that real kind of broad acceptance of this being a disorder that persists into adulthood was understood. And then since the 2000s, there's been a lot of research into the neurobiology and genetics of ADHD, as well as a lot of new psychopharmacology and other treatment modalities for ADHD. A little bit about epidemiology. Estimates vary wildly. It's about 2 to 5% of adults is kind of the CDC estimate. But there are ideas that this is a vastly underdiagnosed disorder, and it's actually upwards of 10% of the population. Right now, per the CDC, the last data that they have, 6% of US adults have an ADHD diagnosis. Over half of them were diagnosed in adulthood. A third are not receiving treatment. This went up significantly during COVID when telehealth became much more prominent and stimulants were allowed to be prescribed over telehealth. But there have been a lot of supply shortages that make it difficult to receive those medications. And today, about a half of patients with ADHD get their treatment over telehealth. So telehealth is a very important modality and one that may be going away if the DEA decides to reverse their rules at the end of 2025. The other important thing about the epidemiology is that women are much more frequently diagnosed as adults than men. And this is for probably a lot of reasons, but we think that the symptoms of hyperactivity and impulsivity are a little bit more identifiable in boys, or maybe not as acceptable in boys as kids, for a variety of reasons. So men tend to get diagnosed earlier than women, which is an important thing to note. A little bit about the DSM criteria. So I know this is like really, in depth and wordy. We're not going to read through this. I encourage everybody to read the DSM criteria for ADHD. But I do want to point out changes that happen in DSM-5 to make this an easier diagnosis to make in adults and to tailor kind of our diagnostic criteria to adults who are presenting because they do present differently. So a few things that to note here. There needs to be symptoms that are inconsistent to the developmental level. So this means that the functional impairments can be relative. That was a change. There was also a change in the number of criteria for adults and adolescents. So it changed from much early in life. I'm sorry, it changed from six criteria to five. So it's a little bit less stringent of a criteria to be able to make the diagnosis. And they've added a lot of verbiage, kind of specifying what to look for in adults rather than children. So not being able to sit in your seat is not a very common, symptom that adults have. Typically those hyperactivity symptoms tend to reduce over time, and it looks very different in adults than it does in kids. They're not sitting in a classroom and they have a little bit more cognitive control. And so you will see kind of bolded here various different criteria that are specific to older adolescents and adults. So these are the inattention criteria. And then these are the hyperactivity criteria. Again, just five instead of six for children. Okay. Um, and then looking through those were criterion A, and then criterion B is kind of the age of onset criteria that was changed from 7 years old to 12 years old. So these symptoms have to be present from an early age. The idea of adult onset ADHD, which is something kind of popular in social media, isn't consistent with the criteria and not consistent with the evidence that we have. This is a disorder that, while it may not be diagnosed till later in life, is present from an early age because it is a neurodevelopmental disorder. There are three subtypes combined, which is the most common: predominantly inattentive and predominantly hyperactive, depending on if they meet criteria for inattentive, hyperactive, or both. But there are, if you kind of spend some time looking on TikTok or other places, there are a lot of other kind of ideas about other subtypes of ADHD that people tend to kind of latch onto. One of them is sluggish cognitive tempo. So you may have heard that terminology. These are people who are they don't have any hyperactive symptoms. They have never had hyperactive symptoms, and they have very profound inattention that looks like daydreaming, lethargy. They're kind of slow, low energy, frequently tired, easy to fall asleep. They're not stimulated. And there's a thought that this needs to be kind of a new subtype of ADHD, and that's an area of active research. I do see in the chat some questions about ADD versus ADHD. So the formal diagnosis is always ADHD. It just depends on the subtype. ADD went away after DSM-3. And a lot of patients don't quite understand that, get a little upset when when they see that diagnosis on their charts. That's an important thing to note. The neurobiology of ADHD. So this is an area that I find very interesting. We have potentially, among the most information about the neurobiology of ADHD, compared to a lot of other psychiatric disorders. The depth of knowledge and study is huge. So there are strong and consistent imaging differences in children and adults that have ADHD versus age-matched controls. And so there's this idea potentially that ADHD is a social construct that we've developed that is not organic in nature, and that is just not consistent with the evidence that we have. When you look at these diagrams are actually diagrams of what are called tracks in the brain. So these are almost like the wiring that are connecting different areas of the brain together and through which they communicate. And so what you will see in the imaging studies is that there's both certain areas of the brain that are underactive in ADHD, predominantly in the frontal lobe, where that controls executive function, decision making, task management, task switching, and then also dysfunction in connectivity between a lot of different areas of the brain. And so this is called kind of the network theory of psychiatric disorders, that it's not just one area isn't working properly. It's that these networks of different areas are not functioning in a way that is optimal, and they're not interacting with other networks in a way that's optimal. What you also see in, and especially kids with ADHD, is that the thickness of the cortex, where all the cells, the most of the actual cells in the brain are on the outside of the surface. And then the inside of the brain is kind of the wiring. We call that the gray matter on the outside versus the white matter on the inside. That layer of cells is thinner. The brain volumes are a little bit smaller, and this is kind of a very consistent finding over time. The diagram is a few examples of some of the tracks that are potentially implicated, but they're quite a few. The other thing to note is that over time, these tracks kind of and the outside, the gray matter of the brain, develop over the course of the first 20 to 25 years of life. And in children with ADHD, that development is delayed. So by several years at least, if not longer. Delay in brain development is a prominent feature of these imaging studies. The impact of this can be different depending on your environment, right? If you have a lot of social support, if you have very engaged parents, if you have a very structured or very kind of a more malleable, maybe school environment that can adapt to your needs, that may result in a situation where you may not get diagnosed until later, because the symptoms don't appear, or they're not as problematic earlier in life. The other thing that I want to really emphasize here, because there's a lot of trepidation about using stimulants, especially in kids, but also in adults, is that when you treat children with stimulant medications for ADHD, these differences start to normalize. And so with treatment, the child's brain, as they get older, looks much more average than in children who are not treated. So I just want to emphasize how important it is to diagnose and treat ADHD early in life, the way we do with other neurodevelopmental disorders like autism. The outcomes are much, much better. There's not as much data in those changes normalizing in adults, probably because by the time you're an adult, your brain is not able to make those changes anymore. Plasticity has diminished. And so early intervention is just crucial. The other thing that I want to mention here is that there's a lot of people out there selling things like brain mapping or using EEGs to diagnose different subtypes of ADHD and a variety of other things like that. These are not covered by insurance. They're cash only. There's a pretty strong profit motive. And there is no evidence in the use of imaging or EEG to diagnose ADHD. That evidence is very weak at best, because there's a lot of variability between people when you do individual studies. And so being able to use these to diagnose ADHD is just not, it's not supported by the evidence. I think I'll leave that at that. All right. So a little bit about the genetics. ADHD is one of the most heritable psychiatric disorders. Okay. It's so the heritability of ADHD is about 80%. It runs very, very strongly in families. And so you also see this in like twin studies, where they compare identical to non-identical twins. The concordance rate of ADHD and identical versus non-identical, it's substantial. So very heritable, very genetic. And again, the point I'm trying to make here is that this is an organic kind of disorder, not a social construct. Many of these genes, there's about 76 that have been implicated, but this is an area of active research, and we're developing better tools every day. But many of these genes are involved in neurodevelopment. As you would expect, they're involved in synapse formation. So synapses are how, the place where two neurons communicate. They're very important. They're very complicated. And so a lot of neurodevelopmental disorders are disorders of synapse formation, or synapse formation is implicated in some way. And then there's also genes involved in neurotransmission. So, for example, dopamine receptors. And we know dopamine is a neurotransmitter that is very important to frontal lobe functioning, where we find deficits in ADHD. The same genes are implicated in a lot of other things: schizophrenia, intellectual disabilities, autism spectrum disorders, learning disorders, also associated with educational attainment or lack thereof, as well as things like epilepsy. And we're going to talk a little bit more about how there's a lot of overlap between ADHD and some of these disorders. They're very frequently comorbid. Little diagram here about what polygenetic inheritance is, because a lot of the questions that I get sometimes is, well, can we just do genetic testing for ADHD? And the answer is no. Each one of these 76 genes has a very small contribution. What matters is the dose that you get. So how many of these genes you get, and in what combination, and different genes, different combinations probably are what result in the different presentations that we see. All right. An interesting point here is that there's some consternation that that rates of ADHD, the prevalence of ADHD has gone up because of overdiagnosis or misdiagnosis. So there's a lot of kind of hand wringing about this, and it is something to contemplate. One of the things that we do know, however, is that for other really genetic disorders, and a good example of this is autism. So there's certain areas of the country where autism rates are much higher than others. Silicon Valley is one. Areas of Seattle are another. And I find this fascinating. We don't know why this is happening, but one of the theories is that people with that have autism spectrum disorder or traits thereof are like much more or much better at skills that like tech companies require. So things like software programming and other things. And so all these people are flooding into these areas, they meet each other, and we start having situations that we call non-random mating. We're kind of selecting people who are have these traits are now more likely to kind of get together and have kids. And thus the dose of these genes that their offspring get is higher than you would otherwise expect. And that's kind of driving up the prevalence of these disorders. And so there are a lot of reasons we could contemplate why people with ADHD might be similar or might be subject to the same kind of forces, but I feel that prevalence is actually going up, not because of overdiagnosis necessarily. I think we're actually underdiagnosing this disorder, but because it is actually becoming more prevalent in the population. Um, a little bit about comorbidities. So almost all of my ADHD patients have another psychiatric comorbidity. The data says it's about 80% of those patients are going to have a psychiatric comorbidity. And frequently it's multiple of these comorbidities. So maybe ADHD, autism, and major depressive disorder. That's not uncommon. Adults, when you're evaluating an adult, they don't recognize their symptoms of inattention or other things as ADHD. They very commonly present with depression, or they present with anxiety or other issues like that. And so screening these people for ADHD is very important to make sure we're not missing something, because if the functional impairments that are driving their depression aren't addressed, then the long-term outcome is not going to be as good. And so we do need to have a high index of suspicion, both in ADHD patients for other disorders and also doing screening when presenting for other symptoms for ADHD to make sure we're providing comprehensive care. Some good examples of this that are evidence-based. Personality disorders are very common in the ADHD population, especially antisocial personality disorder for reasons that are complex. But when you look at, studies of like the jail population, the prevalence of ADHD is upwards of 25%. And a lot of those people also have comorbid antisocial personality disorder and other things. Oppositional defiant disorder is very similar. Substance use disorders, anxiety disorders, depressive disorders. We've talked about autism and learning disorders. And then most importantly, I think this is really, really important. Self-harm and suicide is much, much higher, almost 9 times higher for suicide in people who have an ADHD diagnosis as compared to the general population. So that's something to really consider. The other thing is that there's also a lot of medical comorbidities associated with ADHD. So they very commonly have a much higher risk of type 2 diabetes, high cholesterol, hypertension, and thus cardiovascular disease, respiratory diseases, epilepsy, which we talked about, and smoking is much more common in the ADHD population. Interestingly enough, because there's some thought that this is somewhat dopamine-seeking behavior because of abnormal dopamine transition or neurotransmission, but also because nicotine is a stimulant and these patients are self-medicating. It improves their symptoms to drink a lot of coffee or smoke a lot of cigarettes. So that's just something to think about there. Social media, I don't know. The only social media I use, I kind of stay away from social media, is LinkedIn. And this study was published just a few weeks ago from the UK. And it's been all over kind of my LinkedIn feed, showing that and in the UK, they can do some really interesting studies because pretty much everybody goes to the NIH, the nationalized healthcare system. And so they can do some very robust population level studies. And what they found when they looked at life expectancy and ADHD is that people with ADHD have a much lower life expectancy. So about 7 years for males and about little over 8 years, maybe close to 9 years for females. So that's a substantial difference. Unfortunately, the study wasn't designed to look at causes of mortality to try to get a better understanding around this. But I think we can speculate just based upon the previous slide, kind of what things might be driving this. They also found higher risks in these patients of poor educational attainment, lower socioeconomic status, a lot higher risk of accidents, injuries, and even TBIs, thought to be because of more impulsive behavior and decision making, convictions and incarceration. And we talked about substance use and suicide. So I think this study with very new data kind of reinforces what we already know, that these people without treatment they're at a much higher risk of a variety of negative outcomes. We also know from a very deep body of research in both children and adults that these risks are substantially reduced with treatment. So treatment is very, very important so that we can try to normalize this. I don't know of any studies that look at life expectancy with versus without treatment quite yet, but that's something that's an area of active research, I'm sure. So diagnosis. This could be a whole lecture or a whole hour-long discussion in and of itself. But there's a couple of take-homes here. When we're seeing an adult with ADHD, most adults who present with inattention do not have an ADHD diagnosis. So there are a variety of much more common disorders that are resulting in inattention. One of them is natural changes in cognition associated with age. I've seen that many times, patients presenting in like their 60s with issues with inattention and other things, and it's just kind of it's not pathologic, it's relatively normal. And so it's something to kind of, discuss and kind of dig into. But normal cognitive changes associated with aging is something to keep on the list. Other things that look like ADHD: mood disorders, affective disorders, generally speaking, like anxiety. Anxiety is extremely distracting, especially if it's similar. Um, Trauma-related disorders, so like the hypervigilance and other things associated with trauma is important to screen for. That's a big contributor. And then also, and there's been a lot of interest in this, hormonal changes. So low testosterone in men, which is natural progression kind of as you age, as well as kind of changes around perimenopause. Can contribute to inattention, other cognitive symptoms. And so the treatment for that would be something totally different, not a stimulant. It would be kind of hormone replacement or other modalities. So trying to screen for other psychiatric conditions, and making sure you know what you're treating is really, really important. This is really hard though because of what we just discussed, which is the rate of comorbidities is 80% in ADHD. So very commonly when I have an ADHD patient, or somebody's presenting with this constellation of symptoms, they might have both ADHD and major depressive disorder. And so that's something that I have to keep in mind. We all have to keep in mind when we're doing assessments like this. The How we go about diagnosing ADHD then is through a diagnostic interview. The diagnostic interview is the gold standard. There are some tools that can be helpful to us in making this diagnosis, but going through a solid diagnostic interview, and this may take an hour, this may take several hours over repeated sessions, but getting that longitudinal history over time is really, really important. And we'll talk through that in just a second. Some of the other tools that people try to use or can be helpful are formal neuropsychological testing. I just want to emphasize that formal neuropsychological testing is not a prerequisite to making a diagnosis. It can be helpful. It can help us understand what the specific deficits are. It can help us rule out or rule in other disorders, but it is not a requirement. I know there are a lot of places where pretty much all patients who present with potential ADHD are referred out for psychological testing, but neuropsych testing is it's several $1,000s. It can take months to get in. And so we're really delaying treatment in a way that I think is oftentimes not necessary. The other thing that I'll say, and what the data kind of bears out, is that when you're in a really structured setting doing neuropsych evaluations, patients with ADHD may overperform as compared to how they perform in the real world. And so false negatives are common. This is especially true with like the newer computer-based testing. People with ADHD, they can hyperfocus. That's a compensatory mechanism. It's part of an attention domain. They hyperfocus at the expense of everything else going on. But they can do very well on those kind of tasks. And it's something to keep in mind. There are a variety of screening tools. The one that we use in our clinic is the Adult Self-Report Scale, the ASRS. It's got the first 6 questions are kind of for screening, and then the next few questions are kind of helpful in determining kind of longitudinal functional impairment, and how well we're doing as far as treatment goes. But there's at least 15, 20 different scales, probably more, that can be used. But they're not diagnostic. These are screening tools. So just because you're positive on the ASRS does not mean you have ADHD. Again, we got to go to the clinical interview. Last point here before we talk about the interview: malingering can be an issue. They've presented to my clinic and other clinics seeking a prescription for stimulants, and so if there's suspicion of this, getting collateral can be helpful. And usually once I start asking for collateral, if this is what's going on or it was what I suspected going on, then they kind of ghost. I don't do it very often, but it's something to keep in mind. When you do the clinical interview, just some high points here. It really needs to be very comprehensive. Educational history from all the way back to childhood. So, how'd you do in elementary school? Were you the kind of kid that, the teacher had to constantly redirect? Were you constantly getting out of your chair? Did you get sent to the principal's office a lot? Were there other behavioral issues? How did your academic performance change as we went to higher demand environments? So elementary to middle, middle to high school to college, especially high school to college, because college is a much less structured environment. And so that can be really helpful. We have to identify impairments in two domains, right? And so assessing workplace functioning, interpersonal functioning, because emotional reactivity can be something that people with ADHD might struggle with. Those things are important to assess. And then, of course, you want to screen for substance use and a variety of other disorders, like we talked about, that might look like ADHD, but are not. Um, so that's kind of my approach to diagnosis. And very frequently, it takes several visits for me to feel comfortable that I've got a solid diagnosis on my hands. Um, so there's a little question about tests like QB check in isolation. No, so to make a diagnosis of ADHD, you need to be able to show deficits in these domains, by age 12. And so to get that diagnostic interview and longitudinal history is really, really important. QB check, maybe these structured kind of computer and other evaluations. They are identifying cognitive deficits. They're not diagnosing ADHD. So if you put somebody with other kinds of cognitive deficits in front of those kind of modalities, they will screen positive. That doesn't mean they actually have ADHD, a disorder that starts and presents in childhood. Treatment of ADHD. This we could spend hours on this as well. But for pharmacologic treatments, the most efficacious by far, an effect size of like zero point 0.8, which is like 80% or more of patients are going to respond, are stimulants. They kind of come in two flavors, amphetamines versus methylphenidate based. So some common brand names of old brand names of amphetamines like Adderall, Vyvanse, et cetera. For methylphenidate, Ritalin, Concerta. There is a huge number of treatments now. There are patches. There are all sorts of different kinds of long-acting release mechanisms. There's pills that you take at night that kick in the morning. I mean, there's just a huge depth of potential treatment options when it comes to stimulants. They are the most controlled substances prescribable. They're Schedule II medications. And so just to give you an indication of how controlled, I mean, methamphetamine is a Schedule II medication. It is something that I could prescribe but never would. This requires a lot of, it is high risk for the clinician. And so being sure of your diagnosis is really important. Nobody wants a DEA coming knocking on their door. There's a lot of side effects of stimulants that are potentially dangerous. So these are some of the higher risk medications that I prescribe. They're predominantly cardiovascular. These medications are associated with sudden death and arrhythmias and strokes and heart attacks, those kind of things. Those are rare, but they happen. They are associated with psychosis. So anybody with psychotic disorder, you don't want to give these to. They are addictive. They reduce seizure thresholds, so seizures can happen. They almost always cause some amount of anorexia, by which I mean appetite suppression. They can cause insomnia, and in some people, they can make mood worse. Non-stimulants are about half as effective. We've got a few options here. The most commonly used are Strattera and Wellbutrin. But there's some other kind of long-acting formulations of clonidine and guanfacine. These are really only helpful, the clonidine and guanfacine, for the hyperactive symptoms, which are not as common in adults, so we don't use them very often. But that's the pharmacologic treatment. Psychotherapeutic and behavioral treatment. So I think this is so, what I will say about this is that the goals of a psychotherapeutic intervention for ADHD are not to treat the core symptoms of ADHD, because those aren't gonna, the data says those don't go bet those do not get better with just psychotherapy alone. That medications are really important. But most people, again, have comorbidities. They have a lot of shame because they've struggled in a variety of ways over a very long time, and so the goals should be educating them about their diagnosis, helping them understand that this isn't a personal failure. They just need to try harder. This is a disorder that they need to learn how to adapt to. Reducing shame again, reframing what happened in the past, helping them feel hopeful, reducing kind of the more maladaptive coping mechanisms like substance use that are common in this population. There's also health and lifestyle risky behavior that's common in this population, such as smoking, such as kind of more risk taking with sexual behavior. Their relationships can be impacted by their symptoms. Couples counseling sometimes can be helpful. And then, yeah, we're doing the same things we would do in a patient that has depression and anxiety in terms of treating that. Um, the best data is with cognitive behavioral therapy. It's got the largest evidence base in ADHD. And let me just say this. So, cognitive behavioral therapy might be some of the easiest therapy modality to study, just because it is very structured and very you can make it modular, and you can study it a lot more easily than something like psychodynamic psychotherapy that's a little bit more less structured, a little harder to study. But what is important, however, is helping patients learn how to manage their symptoms behaviorally through compensatory skills. So it's all about skills building, task lists, digital tools, using your phone for reminders, using your phone calendar so you stop forgetting appointments. This is called in other places organizational skills training, and it's a really important part of this. The other kind of one that I recommend to a lot of my patients is called the Pomodoro technique. Some people call it the Apple timer technique. Basically, the idea is that you break tasks up into small increments, like 20, 25, maybe 30-minute increments. You work for 30 minutes or so. The timelines can vary depending on what you're doing. And then you force a pause for like 15 minutes. You force the break, and then you go back to the next task. So setting realistic expectations about how long attention span should be, and using tools to help make sure that the brain is getting a break so they can focus adequately for that, 30, 40 minutes is important. Routines are really important. There's really interesting data that mindfulness exercises actually help reverse some of the neurobiological changes in ADHD. So we're actually changing neurobiology with mindfulness, which is something is seen outside of ADHD too. And then restructuring kind of thought processes. So if you haven't been diagnosed until adulthood, very likely there's a lot of maladaptive thinking going on here that needs to be identified, brought to the consciousness and seen, and then, maybe adjusted. So common one example here is like all or nothing thinking, driving procrastination. And procrastination is very common in people who have ADHD, trying to avoid tasks that require a lot of sustained effort is important. Um, and then a few last kind of questions that I hear all the time when it comes to ADHD. Do screen time, video games, social media increase ADHD risk? So there's a lot of data on this, actually. And while there is an association with people with ADHD spending more time on screens, there is no evidence to suggest that the increased use of screens actually increases the risk of developing ADHD. So that is something that is not substantiated kind of by the evidence. And I know it's something that a lot of people worry about. But I think, it's probably not one of the reasons why ADHD is becoming more common of a diagnosis. I think that's a combination of better awareness, as well as probably better, or actually like real increases in prevalence of this disorder. That's something that I get asked about a lot. Um, uh, and then the question in the chat, for children with ADHD, do you think it's helpful to recommend that parents limit screen time? Um, I think for most kids, screen time limitations and really a lot of structure around screen time is really helpful. In kids with ADHD, it's going to be a little bit hard because people with ADHD, kids included, are seeking novel, very stimulating things constantly. They don't like boring. Their brain doesn't respond to it. It's constantly looking for novel things that really stimulate dopamine release because dopaminergic neurotransmission is reduced, and so that kind of drives a lot of the habitual use of screen time. I think I think having structure around it is important, and limiting it can be helpful. Um, uh, is there any evidence that playing video games helps the ADHD mind to focus on the outside world? That's a really interesting question. So a lot of games are designed in a way that doesn't potentiate a kind of long-term focus and concentration. It's like small, very fast tasks which ADHD people are good at versus one long prolonged task or kind of planning something in the future. So, for example, I read a quote from a patient with ADHD that said, if my boss asks me to do something in 10 minutes, I have it done in 5 and it's awesome. If he asks me to do something in 2 weeks, he'll get it in a month, maybe. And that's very consistent. And so there actually is one FDA approved digital treatment that's kind of like a gamified version of this for kids, that has some evidence to be helpful in helping kids with long-term planning. So kind of moving that bar out versus what's going to happen in the next 10 seconds, which is how most video games work. Um, I can't remember the name of it at the moment, but I will pull that for you and try to have that sent out actually, because I know that's something that a lot of people are interested in, but there's only one. So if you Google FDA video game for ADHD, you'll probably find it. A couple other things I wanted to hit on here. Do food dyes cause ADHD? The answer to that is they don't cause it. But there's actually some evidence that they can exacerbate hyperactivity in kids that do have ADHD. They're acutely sensitive. This is more specific to red number 40. They're kind of labeled with numbers. Red number 3 was actually banned a couple of weeks ago by the FDA because of carcinogen concerns and other things. But there's evidence that doing restriction diets, where you eliminate food dyes from the diet in kids with ADHD, leads to better outcomes. Whether that's because you're eliminating foods that have a lot of dyes, which is like, processed stuff like Fruit Loops and Twizzlers and other things like that, or it's the dye themselves, hard to say. And then I'll get to a couple other questions here. How would an older adult present with ADHD? So a client who is more forgetful. And so they present typically most adults with much less hyperactive or impulsive symptoms. That tends to get a little bit better with age, but it's predominantly inattentive symptoms that adults, especially older adults, present with. The important thing there, though, is to remember that just by definition, however, they need to, you got to get that history and really dig back to see if there were substantial functional impairments going back to childhood. That's something that you have to be able to document. And so very frequently, I'll find older adults coming in with issues with task management at work. Sometimes it's like relationship instability, and impulsivity, in the context of like emotional regulation, that can be really difficult. Maybe they have a history of like frequent divorce or other things, estrangement from other people. So interpersonal issues, a lot of issues with management of finances. Probably the single most common or well understood phenomena of adults with ADHD is a history of driving too fast, speeding tickets, and other things. That's actually very common and something that I do ask adults about. What's your driving style like? Are you an aggressive driver? Are you kind of a laid back driver? That can be helpful. And then the other thing that I ask, there's a few kind of questions that I ask commonly. And one of them is that, do you feel like your achievement is like correlates with your level of smarts? And I kind of ask it in a little bit of an awkward way like that, because if they are inattentive, usually what happens is like, what can you clarify? But also, this is kind of diagnostic in some ways. You will find that these adults just they are very potentially they're very intelligent, but they have not achieved academically or occupationally in a way that's concordant with their what you would expect given what you're saying. Um, and then the last one, and I really want to touch on this, is ADHD a true mental health disorder or a trait we should not pathologize? Because this is like something I see on social media quite a bit nowadays. And I'm hopeful. I also read a quote, that, the quote is, having ADHD is like being tall in a world of two short doors. And like maybe the world just needs to, make the doors taller. And there is some truth to that. Yeah. When you look at any traits, even anxiety or depression, these things exist for a reason. At some point, they were helpful. If we talk about anxiety, for example, thousands of years ago, when the world was a much safer and much different place, anxious people probably didn't get into dangerous situations as often, right? It was a survival advantage. Evolution doesn't care about how we feel. It cares about us surviving. And so depression is the same way. People with depression probably didn't, go engage with strangers who might be dangerous. They probably didn't go pick up an axe and go to war. I mean, so these things and we can probably hypothesize that ADHD probably had some of these advantages at some point. But I would hope that, based on the data about the biology and the understanding that this is an organic disorder, and the data about the outcomes without treatment being substantially poorer for these people, that we kind of get to a place where we understand that this trait, and same with depression and anxiety, these are no longer adaptive. These are not helpful; they're harmful, and to provide best functional outcomes, and we need to treat. Um, and with that, I will open it up to any other questions anybody has. I went a little over, sorry.
No, you did great. And I love that people were adding questions into the chat as you
Yeah,
went along. I think that's fantastic. So please, y'all, if you have any others, or if you wanted to unmute and use your voice, that is more
yeah,
than welcome here.
please do. Hello, Nancy.
Hi, I'm wondering if there's a particular printed form that you use to do the diagnosis, to do the interview that provides you with the diagnosis.
I do not use a particular printed form, unfortunately. There are, if you go to, it's sorry, it's the textbook, russellbarkley.org. Russell with two L's, russellbarkley.org. He's one of the premier experts on ADHD. He's written a ton of books, both for clinicians and for people with ADHD or trying to understand more about ADHD. He's got the kind of the gold standard textbook. It's like 1,200 pages. I read the whole thing in fellowship. He does have some information there about kind of what would go into a diagnostic interview for ADHD and how best to approach it. I typically kind of go in order, very chronologically, more or less, and kind of put the information in my note. And we start from like early childhood. Did you walk and talk, kind of, when expected? And we just go from there. Yeah.
Oh, okay, thank
Yeah.
you.
No problem.
Next question said, any thoughts on deciphering between ADHD and OCD?
Um, so That's a good question. Both can present with inattention and impairments in focus and functioning in that way. The biggest difference is that you know, with OCD, you typically see it's a pattern of repetitive thought processes. So it's not like the thoughts are just coming one after another and distracting. And they're different kinds of thoughts about different things. They're usually focused on one thing. And the same goes with the compulsions. They tend to not be the hyperactivity in ADHD tends not to be homogeneous. It's a lot of different things. Whereas in OCD, the thoughts and the compulsions tend to be much more narrowly focused. And I think that's probably one of the biggest differences there that I would see. Yeah.
All right. And then the next question we had is there any connection between, or is there a relationship between sugar consumption and ADHD?
Super interesting. I don't there have the studies that have specifically looked at sugar, I think have been negative from what I understand. I find that a little bit and that's true for a lot of other disorders as well. The only thing that gives me pause about that is these studies where they exclude all food dyes from the diet. You're really excluding a lot of like high sugar processed food things. So I think so it's very hard to do a study where you're keeping the diet the same while excluding, red 40 or 3 or a variety of others. And so I do think diet plays probably somewhat of a role in terms of magnitude of symptoms, but I don't know of any like hard data to support that. It's kind of one of those interventions where it's like, risks of it are nil, and benefits, even if it doesn't help the ADHD, it's probably a healthier diet to begin with anyway. And so something that I don't know, like always recommend off the top of my head, but or off the bat. But if a patient wants to undergo that, I'm totally fine doing that. Try it out. So solid questions today. Thank you.
I had one more
Any?
similar to the sugar. So
Yeah,
I work
please.
with children and adolescents. Sometimes we
Yeah.
have parents that are really apprehensive about a stimulant.
Yeah.
I actually had a parent the other day tell me that she didn't want to start him on medication, but she will give him an energy drink in the morning. It has a lot of caffeine, and she thought that that was helpful. And I didn't know like the research behind that, so I didn't want to say too
Yeah.
much, but I did just, to speak generally about it's probably not a good
Mm.
idea to give them a whole bunch of caffeine and then send them to school. But what are your thoughts on that? Have you heard anything like that with caffeine?
Yeah, so adults with ADHD very commonly they'll present with like, I drink a pot of coffee a day because caffeine and similar to nicotine, these are stimulants. They can actually help with symptoms. The problem with caffeine is that it has a half life of like 12 hours. It's an exceptionally long-lasting stimulant, and kids and adults with ADHD already have as part of their constellation of symptoms, very commonly difficulties with sleep onset, sleep maintenance, and caffeine can really exacerbate that. Whereas the stimulant for instant release, it's got a half life, a duration of action of like 4 to 6 hours. And so I think the risks of affecting sleep are much less. The other thing that I'll say is yeah, there is some like trepidation in parents, and I understand that. I think there's a lot of like distrust of pharmaceuticals generally that contributes to this a little bit. But I think just based on the evidence, when we see that, brain structure and development is catching up to normal, and is becoming more average as compared to not average, while the brain is still in a very plastic state, and we can do that. I think that's by far the most compelling evidence. The other thing that I'll say is there's a very deep body of knowledge on outcomes in kids with treated and untreated, and the risk of incarceration, substance use disorders, and other things. Like a lot of parents have worries they're gonna, start drug seeking or other things if they're already taking something like Adderall. And the converse is true. I mean, it really is very protective. The biggest side effect I've seen in kids when I was treating them is they need a lot of calories. Stimulants suppress the appetite, and so that is kind of a struggle. So you do see that kids on stimulants are a little bit shorter sometimes, if they were not able to kind of compensate for that somehow. But I think the neurobiology data is like quite compelling. Yeah. Yeah.
We have some coffee talk. Have you ever heard of coffee or caffeine making people sleepy? And then someone else that I'm curious about why that happens for some people too.
Yeah, it's interesting. I've heard of that too. It does for some people, and I don't know of any data to suggest that caffeine is in ADHD, like that effect is like diagnostic of ADHD of caffeine specifically. But what we do know is that people with ADHD who take a stimulant, they kind of relax. They slow down. They don't necessarily get sleepy, although that does happen sometimes if the dose is too low. So this may be a similar phenomena. But whereas people without ADHD who are on a stimulant get revved up, they get chatty, they talk more. And so that can be a helpful kind of diagnostic tool as well sometimes. Um, Eating disorders and ADHD. Yeah, that's a very that would be a very difficult situation. The thing that I'll say about eating disorders is that so most people with an eating disorder, the mortality risk is cardiovascular. They die from sudden death due to arrhythmias and other things. And so, generally speaking, if I have a patient who has an eating disorder and comorbid ADHD, their nutritional status needs to be well monitored and intact. Um, and we'll sometimes need to get a cardiology clearance before we proceed with treatment to make sure that it's safe. That's especially true in bulimia, where there is a much elevated, much higher risk of seizure due to electrolyte imbalances. And so there are people with eating disorders who do abuse stimulants and other medications for both appetite suppression and other purposes, like laxative abuse. But I would say it's just something that you need to approach very cautiously, so that you're doing it safely. More good questions. This is awesome. All right. Any other questions today?
Did you say that the half-life, that the duration of caffeine is 4 to 6 hours?
I said it's about average 12 hours for caffeine. It's really variable in people. Livers metabolize caffeine at like very variable rates, but on average, it's I think the take home is that it's very long. So if you have a cup of coffee at 9 a.m., at 9 p.m., a lot of that caffeine is still going to be in your system. Um, and so it really can affect quality of sleep for a lot of people. One of the first things I do when I'm treating insomnia for anybody is assess caffeine use and try to dial that back down, because it can really affect quality of sleep, and sleep architecture as well. For being a generic medication, why does Strattera frequently require prior authorization? I'm not sure. It's cheap. It's generic. I had to fill out a prior authorization for Lexapro yesterday, which is like 10 cents a pill. So I will say that I'm going to chalk that up to insurance companies doing their thing. I don't know how else to explain that. Yeah. All right. Um, well, I appreciate everybody coming. Thank you so much for being here. Julia, would you like to close us out?
Yeah, absolutely. I do know that I think our recording probably may have chopped off that beginning piece. So I don't know if you could skip back to just the slide that has our info. So then people who are watching this in the future, hello from the past, can
Yeah.
get that. I also want to let you guys know that I dropped in some links,
Oh,
including a link to, well, that's important. Uh, at the bottom here is our phone number. This will be sent out in the recording, as well as our contact information, which if you need to make a referral for med management or psychotherapy, we are in network. We also have providers via telehealth throughout the state of Texas. We do focus on adults, and I'll include all of that information as well. I know that we also have lots of reasons why we might need to refer out to other therapists, especially for people who maybe come to us and they're not an adult or they want to find a therapist for their child. So I will include that information in our follow-up as well. And then finally, I just want to let you guys know that this is something we want to do in the future. So if you want to attend another one of these webinars, we plan to do them every month. Feel free to reach out. Let us know if there's a topic you'd like to learn about, chat about, and invite a friend. I know a lot of you guys are in telehealth, and one of our, and even if you're in private practice in person, it can be isolating doing this work. So I think it's really important to have times to see other faces, connect with other people, ask questions. So that's really one of the reasons we're doing this as well. Cool. Well, thank you guys so much. You'll hear from me with all of that follow-up information, and know that our door is always open. So thanks for being a friend and being a colleague, and we look forward to connecting with y'all again in the future.
thanks,
Cool.
everybody.
Take care.